Welcome back to another episode of Coffee with Doc. The suggestion just came in that we change it to protein shake with Doc because that's what's in my cup. It's too late in the day for coffee. I think caffeine after 10 o'clock in the morning is detrimental to your sleep. And then sleep is one of the most important things we can do. So as far as recovery. So for me, no caffeine after 10 a.m. So, on to, I think the last time we left off, I left you guys with a question about testosterone levels in women, and kind of what is the more predominant hormone in women. And I believe the question was somewhere along the line, is the most predominant hormone in women estradiol, progesterone, or testosterone? And the answer, drum roll, terrible drum roll, is testosterone, believe it or not. Most physicians are unaware of this. The reason that most physicians are unaware of it is because when we test labs, if the physician indeed tests for a testosterone level in women, and they compare that to the estradiol level, typical estradiol level, depending on the phase, but let's use the phase when it's the highest in ovulation, it can go up anywhere from 150 picograms per milliliter to 200 picograms per milliliter. Where the normal range for testosterone, again, depending on age, can range anywhere from 0, can't believe that 0 is a normal number or level, up to 50 in a normal, healthy woman. But that's in nanograms per deciliter. And the issue is most doctors are lazy and they won't do the conversion. So if you just say, well, the upper end 50 of testosterone and the upper end of estradiol there's 200. Well, 200 is 4 times more than 50, and you're correct. The problem is, if we remember back to second grade math, we did word problems. If you just put down 50, you got the answer wrong because they went, what is it, 50 chickens? 50 what? So when we have 50 nanograms per deciliter, if we want to convert that to picograms per milliliter, that equals 500 picograms per milliliter. It's a factor of 10 more. And so when you look at these lab values, if you multiply the testosterone level by 10 and compare that with the estradiol level in a normal, healthy woman, you will see that she has more testosterone than estrogen, or estradiol in particular. So that's kind of a great intro to what we're going to talk about is testosterone in women. And so I just answered the kind of the first question that we have on here is, do women have testosterone? Yes, they should, and in an abundance compared to estradiol. It is produced in the ovaries and in the adrenal glands. That level is about 1/10 to 1/20 that of optimal males' testosterone levels. So while it's much more prevalent in higher levels in males, it's still the dominant hormone in females. Low testosterone in women can present in a lot of different ways. Generally, it's fatigue, lack of libido. I kind of like to answer that question by saying, well, what are the beneficial effects of giving testosterone to a woman who has a low level? And it's the improved energy, an improved overall sense of well-being, strength and endurance get improved, body composition. It helps to get rid of body fat, and it also helps to decrease cellulite. Bone density. Although this is kind of controversial because bone density is mostly driven by estradiol, but testosterone does play a role because its role, I think, is more in the improvement in strength, and that improvement in strength then yields more weight resistance activity, which will lead to axial loading, which increases bone strength. So I think it's kind of a secondary way in which it does that. The libido is improved, the sensitivity of the erogenous zones, nipples, clitoris, etc. They're also improved. Decrease in visceral fat, subcutaneous fat. So, these are some of the benefits of giving testosterone. What woman needs testosterone? Well, any woman who's suffering from those symptoms and has a low testosterone level. Is it safe? Well, testosterone is absolutely safe because it's an endogenous hormone. Now, we want to try to keep it within physiologic limits, but some women prefer or function better at a little higher than physiologic limits. So when we replace testosterone, my goal is to try to get to that 40 or 50. However, I have plenty of my female patients that walk around with levels of 100 to 150. And they feel amazing and they have no androgenic effects. I think we covered this in the previous episode, but it's important to kind of touch base again. Testosterone has both anabolic and androgenic effects. Anabolic, that's the muscle building, strength, muscle building. The androgenic, those are the ones that are the things that we associate with men. The deeper voice, the facial hair, male pattern baldness, body hair, acne, etc. The dosing, physiologic dosing for a woman should not cause any of those issues. Typically, those androgenic effects are not seen in a female until that level gets around 400 to 450, according to the medical literature. I don't like to go anywhere near that level with my female patients because they're going to run into those problems. Dr. Rebecca Glasser has written some papers on this, and she is an oncologic breast surgeon, breast cancer surgery. And she has her post-surgical breast cancer patients on testosterone replacement, and her average level was somewhere around 200. If I recall the literature, it was about 196 nanograms per deciliter. And very few, if any, had any androgenic side effects to report. They all felt pretty good. And the reason that she kept that level up there is because her studies and other studies have proven that testosterone in women is anti-proliferative to breast cancer. And I actually, if I can flip through here, I can find the article on that. There it is. So the reason it does that, I believe it's because it inhibits the estrogen receptor. I have one here, therapeutic activity of testosterone in metastatic breast cancer. Testosterone was the most common line of hormone therapy for that disease of breast cancer. This was in a study that was refractory to other treatment forms with hormones. And when they say hormone therapy for breast cancer, they mean killing all the rest of the hormones, killing the estradiol, blocking the estradiol, getting rid of the progesterone. And so when we gave these women testosterone, and they were given big doses, 250 milligrams once every 2 weeks of testosterone propionate. And then what they found was regression in disease in 17% of the patients, stabilization in the disease in about 41.5%. And the remaining 41.5% of the disease progressed, but it did show some benefit in over half of the patients. So, it's the testosterone reduced E2 induced proliferation by about 40%. So the testosterone just kind of battles the estradiol in breast cancer, and it's really working on the estradiol receptor. So there's lots of good papers out there to show this. Very important hormone for women, though. So typically, if a woman, you're not going to see the virilization with physiologic replacement, and only when women that are using testosterone, they use excess amounts, i.e. female bodybuilders, they run the risk of those androgenizing effects. And it's because I've seen some of the levels in some of these women, and they've been greater than 2,000 nanograms per deciliter. And that's higher than the upper end of the normal range for men. So when you go outside of that realm, you're probably going to see a lot of these androgenic effects take place. Does testosterone restore a woman's libido? It's a great question. It really depends on the baseline libido in the woman. So there are a lot of women that have very poor libido to begin with. They've never had a great sex drive their whole life. And I tell those women, we're not going to make you somebody that you've never been. You're not going to go from somebody who's not very interested in sex, and even during puberty, it wasn't much of a concern. We're not going to turn that person into a nymphomaniac, that's for sure. But for a woman who has had a normal, healthy sex drive, and they go, into menopause or going further down, even so on birth control pills, and they lose their libido, that is a very good indication of a drop in testosterone. I think an important point is to talk about birth control pills and the typical way that most physicians do hormone replacement, whether it be bioidentical or not. And a lot of physicians forget about testosterone. So in birth control, it's really suppressing the endogenous hormone production of estradiol to lead to ovulation. So we're kind of suppressing that ovulation. Well, when you do that, you also lower the natural testosterone production. So women on birth control have lower testosterone levels. They have lower normal estradiol levels and low progesterone levels because they're using a synthetic form of these hormones, and it shuts down the natural production. Versus a woman who is getting hormone replacement, whether it be bioidentical or not, if the physician's not giving testosterone. And there's a great graph I have, and we can kind of put this up for people to see. But what you'll see is the normal, healthy woman's testosterone level is about 400 to 500 nanograms per deciliter, starting from about age 18 and going on, to about age 60, right? Or when they start to go into menopause. And what ends up happening is when they go on hormone therapy, if somebody doesn't replace their testosterone, their levels go down even further than the woman who's not on hormone therapy. So it's pretty interesting how the system works. So it's very important for a physician, if you're giving back progesterone, you're giving back estradiol, you also have to give back testosterone. All three hormones need to be in balance. I'm just kind of looking at some of our questions because I think I just covered all of them. What about DHEA? DHEA has a lot of benefits in women. I think at lower doses, it is a precursor to testosterone. So testosterone, estradiol, progesterone, these are all hormones made from cholesterol. And the first product that the body makes, or the first hormone that the body makes from cholesterol, is pregnenolone. Then pregnenolone can go down the pathway to create cortisone. It can go down another pathway to create progesterone, or it can go down the pathway to create testosterone and estradiol. So it's very, very important. It's the mother hormone, pregnenolone. Well, when it goes down that pathway towards testosterone and estradiol, it goes pregnenolone, DHEA, which can go to estrone, or androstenedione. Androstenedione goes to testosterone, and then testosterone can aromatize to estradiol. So you kind of see the importance of all of these hormones. I give DHEA to younger women with healthy ovaries at low doses if they have low testosterone, to see if we can give their bodies the building blocks to start to produce a little bit more testosterone. So if you give it, the building material, we'll see if it kind of goes on and improves the natural production of testosterone. If it doesn't, we can look directly to direct testosterone replacement therapy. But even then, once we give testosterone, we want to support that with a little bit of DHEA, because higher levels of DHEA improve free testosterone levels. And that's really where the rubber meets the road, is we're looking for a free testosterone through a lab core value of about 3 to 6. And that's when women feel the best, is when that free testosterone reaches that level. The total testosterone is really not as important as the free testosterone, and there's plenty of studies to validate that. Another question that I think is very important to address is kind of what are bioidentical hormones? And I've heard people give different definitions, but my understanding is pretty clear. It's bioidentical, it's the same chemical structure as the hormone that your body would make. So when we talk about testosterone, it's a particular carbon ring structure, and it looks a lot like estradiol. There's a hydroxyl group and a double bond, and it's basically the only thing that makes the difference between testosterone and estradiol. So we give testosterone, it's the exact same molecule. You change one molecule in there, it changes the action. And it's so important that if you look at a testosterone molecule and you look at an estradiol molecule, and maybe we can put these up as well, you'll see that there's not much difference. And the little differences make a world of difference on how it affects us at the receptor site. So, bioidentical testosterone, whether it be testosterone in a cream, whether it be testosterone cypionate, enanthate, it's still all the same. It's bioidentical. It's the exact same testosterone. Now, if you change that and you turn it into something different, you can turn it into a plethora of some of the what I call designer steroids. And there's a plethora of them, and they come from different bases, but they're all based off of testosterone or dihydrotestosterone. And then they add little things to them to get little, other molecules here and there in the chain to get different effects. But ultimately, bioidentical testosterone is that. Bioidentical estradiol is the exact same molecule as estradiol. This is kind of interesting in how we came about this term, because when hormone replacement first came out for women, it was in the form of CEE, which is conjugated equine estrogens. The first one that most people know about is Premarin. Premarin stands for pregnant mare urine. That's where they got this hormone from. They would just take the urine of pregnant mares and they do it however they did the magic, but they came up with Premarin, and women were taking it. Well, the problem is that it has, I think, 12 other equine estrogens in it. So these are horse estrogens that are not endogenous to the human being, but they can bind to the estrogen receptor and have an action. And a lot of times it's a longer duration of action because our body doesn't know what to do with these estrogens, doesn't know how to metabolize them. But it also had E1 estrone and E2 estradiol. But the ratios of them were flipped. So a normal, healthy menstruating woman has about 80% of her estradiol, or estrogen is in the form of estradiol, and about 20% is in the form of estrone. And it's like 19% and 1% potentially in estriol. Estriol is the third human estrogen. It's very, very low in production, primarily produced by the fetal liver during pregnancy. So the issue was, yes, we're giving these estrogen hormones to women, and what did we see? Well, the original idea was to help them with their bone density, because osteopenia and osteoporosis as women went into menopause is a big issue. So they started giving the hormones, and lo and behold, they found that a lot of these women felt a lot better. Their hot flashes went away. Their night sweats went away. Their energy was better. Brain fog went away. They were just feeling like $1 million. They're like, wow, we're on to something. What they didn't realize was giving this unopposed estrogen increased the risk for uterine cancer. And so we've seen an increase in uterine cancer in the women that still had an intact uterus. But for every single study that they did, even with the conjugated equine estrogens, and since then when we've looked at both CEE and estradiol, bioidentical, and found that it reduced the risk for breast cancer, which was kind of counterintuitive. And every single doctor says, if you take estrogen, you're going to increase your risk for breast cancer. But the studies don't validate that. So where the increased risk of breast cancer came is when they figured out the uterine cancer issue, and they came in and gave progestins. You notice I said progestin and not progesterone. Progesterone is bioidentical what the body produces. If we give micronized progesterone, bioidentical progesterone, we do not see an increased risk in breast cancer. We actually see a little decrease. When we give the progestins, medroxyprogesterone acetate, MPA, and there's a plethora of them that have come out, each and every one of them increase the risk of breast cancer. Such so that I don't even understand why this is even being prescribed to this day, because we know that these are pro-carcinogenic to the breast tissue. But that's where the whole concern for breast cancer and hormone replacement came, is because of the fake progestins being used instead of progesterone. Why did they do that? Well, it's anybody's guess, but I would think because we cannot patent a natural hormone, but we can make a variation of it and put a patent on there, and you patent a drug and you got big money. Big pharma has big money and big influence. So they did that. I think it was purely monetary. And I hate to think that they wouldn't care about the health of women, but the fact that these are still out there and prevalent and being prescribed kind of indicates that that may be the case, because every single study shows an increase in risk of breast cancer and breast cancer recurrence when these progestins are used. So that thing that kind of covers the questions that were put out to us to talk about testosterone. And I did a little history on the bioidentical hormones. We had a question from the internet. It says, I cannot concentrate at work or think clearly any longer. I'm forgetful all the time. What could be causing this? Should I worry about having Alzheimer's? Fair question. It would be nice to have this person in front of me or have a little bit more history, but I would suspect that there's probably some degree of perimenopause or even menopause. And so as these hormone levels drop, a lot of women get brain fog. And that brain fog kind of leads to CRS, can't remember stuff. So that could be a big part of this. If that's not the case, my next thought would be to look at the diet and see if this person's eating a lot of sugar or inflammatory foods. These inflammatory foods, they do cross the food doesn't, but the inflammation crosses the blood-brain barrier and causes brain inflammation. There's a great book called The Brain on Fire that kind of describes this. There's probably 1,000 other books that talk about this. But that could be an issue. We know that dementia, to include Alzheimer's, is now considered type 3 diabetes because the glucose in the blood vessels is pro-inflammatory. And so, is this early onset Alzheimer's? Well, I don't think we have any real good tests. And that's a big area of study now, is looking for these biomarkers that we can find in the blood or imaging studies that we can do to kind of predict the probability of Alzheimer's disease. But, some of the easiest things that we can do is just maintain healthier blood sugars, keep our A1C low, keep our blood sugars low, try to avoid those insulin spikes. That decreases inflammation in the brain. Alcohol is another big brain inflammatory component. So even moderate or mild alcohol intake is not healthy. The old studies, and I used to love to quote them, that would talk about having a glass or two of wine a day was healthy and beneficial. We liked that conclusion, but I don't think when we heard that conclusion, we said, well, who is your control group? We liked the end of it, so we said we're gonna ignore who the control group was. But come to find out, when they've looked back at these studies, that the control group was full-blown alcoholics. So when you compare somebody who only drinks once or twice, or one or two drinks a day, versus somebody who's an alcoholic, of course one or two drinks looks like it's a lot healthier. But they've since redone a lot of these studies and compared the one or two drink a day person to the non-drinker, and found the non-drinker does so much better. So alcohol is a toxin to our systems. Anytime that you drink alcohol, you're just making a conscious choice to put a toxin in your system, then you get to also make the choice of how much you're going to put in there. And sometimes there's a price to pay. And the more that you do, the greater the price to pay. So just be wary of that. But I don't think I have enough information for this individual, but these are the things that I'd be concerned about. So really, if it's not hormones, more than likely it's dietary. And, even Alzheimer's is a very big dietary component. Just as an aside, and kind of goes along with the alcohol, but we see people with lower B12 and folic acid status, and that relates in a lab test called homocysteine. And if the homocysteine level is high, it indicates one of a couple things. Either you're not getting enough B12 and folate in your diet, or you're unable to methylate it because you have a gene SNP or deletion in the gene sequence of the MTHFR gene, and you're unable to methylate the B12. Even if you're taking plenty of it, if you are unable to methylate it, it will not get into the system and do its job. And so this homocysteine level goes up. Alcohol also depletes our B12 levels. So we see higher homocysteine levels in alcoholics. And this is related to increased risk for Alzheimer's. So if you have a homocysteine level above 10, then you probably want to be looking at getting a B12 supplement that's methylated. So instead of cyanocobalamin on the label, you want to find something that has methylcobalamin in it and have some folate in there. Now, my understanding from the folks that I've listened to in lecture as far as the folate goes is you can get methyl tetrahydrofolate, but it's not as necessary because the body generally methylates that back and forth pretty easily. But I'm not sure if that's the case if you have the genetic mutation. So if you're not sure, then just get a really high-end methylcobalamin with methyl tetrahydrofolate and you should be fine. But that concludes our podcast today. It wasn't as verbose as some of the other ones, but hopefully you learned something, and we'll see you again next time.